It's always so much fun to hear their stories. Helen Kaupang is our speaker this morning. She was Helen Peak when I knew her at Montrose High School. She's the daughter of Dr. Jim Peak and Christine, her stepmom. She graduated from Montrose High School, went on to Fort Lewis College, got a degree in human services, came back to Montrose in 1975 with her husband, and in 1983 actually worked for the CBI office here. Those of you who have been here a while remember we did have a CBI office. And that was kind of her springboard, she said, to the DEA. In 2017, she retired after 29 years with the DEA and spent the latter part of her career doing investigations into the opioid epidemic. And I put all of that in the email, so I won't go into the more minute details, but we'll wrap it up with the fact that she's currently doing consulting work involving litigation against the pharmaceutical companies. And Jim and Christine had heard so much of her story and found it so interesting that they said, maybe we could get her to come and speak. And so we did. We're honored to have her, and I'll turn the mic over to Helen.
Thank you, Kathy. Kathy and I have been communicating, and I thought, I know this person, and I had a picture in my mind of what she looked like when she walked in the door. I had a picture in my mind of who Kathy was and what she looked like, and she walked in the door this morning. I went, that's Kathy. so the more we change, the less we change, right? It is truly an honor to be here this morning, and yes, you're not hearing. Okay.
Really close, speak it.
I really love microphones, just so you know. It's an honor to be here this morning and to come back home and to be able to share part of my story of where I have been and some of the things that I've seen. I want to give special credit, though, to my father. It's truly an honor, Dad, to be able to be here and to say that growing up in a medical household and seeing the medical community in Montrose do things right made all the difference in the world on how I was able to respond as I went forward in my career. So, I love you, Dad, and this is for you. So, I want to give you a couple definitions of what things are and what things are not. I was not a DEA agent, I was a diversion investigator. Two totally different worlds within the DEA. A couple, yes?
They still can't hear. Try turning the
Volume?
We'll have to. Yeah.
Is that better?
Yeah.
Okay.
Can you hear now?
A little bit. A little better.
Okay, is this good? Okay. I want to give you a couple of definitions so that you can kind of understand where I am coming from. Drug Enforcement Administration has several major career groups within it. The one that is best known, of course, is the special agents, who are the gun carriers. They are the ones that do the undercover work. They're the ones that go out and work the street drugs, the heroin and the cocaine and the methamphetamine. A lesser known group within DEA until recent years was the Office of Diversion Control. And the Office of Diversion Control covered legitimately made, legitimate pharmaceuticals that had a medical need. Okay? So we were working, and I was a diversion investigator, that was my area. So the work that we did had to do with from raw products being brought into the country to produce your narcotic drugs, poppy straw and so forth, to create morphine and to create some of the narcotics, through the whole manufacturing and distribution realm down to the pharmacies, out to the doctors, the veterinarians, the scientists, and then to the end user, which is the word we used for the ultimate patient, whether that patient was a person, an animal in a veterinarian clinic, or a research subject, okay? So within that realm, DEA gave registrations to everyone who was, well, not everyone, but there were particular entities within that chain that had to have a registration from DEA. We were the ones that granted that registration, and if need be, we were the ones that took that registration away. So that being understood, the other thing I think is important is for you to understand what a controlled substance is. A controlled substance is actually a drug that the Food and Drug Administration has done the research on in working with DEA, and they have decided that there is some abuse potential to that, and both psychological and physical, okay? And there are 5 schedules of drugs, Schedule 2 being the most potent drug with the highest potential for abuse and misuse that is medically acceptable, down to a Schedule 5 drug, which has very low abuse potential, but there is still some there. Okay, so when you hear that range and you hear a controlled substance, that's what we're talking about, is particular drugs that have been deemed to have high potential for abuse and misuse. And that's as opposed to something buy over the counter, or just a regular prescription drug like amoxicillin, or something that you need a doctor to care for, but it's not going to be addictive in nature. Right? So the world of controlled substances is the world that I lived in for 29 years. And I think it's extremely interesting when I hear people talk about the epidemic that's going on right now as if it is something new. The opioid epidemic is as old as we are and older. I want to tell you a few stories. What I'm going to do is kind of walk you through my career and some of the things that I saw at different points in time during my career. And then I'm going to leave a few minutes at the end to sort of talk about the last couple of years and some of the things that came to culmination. So I came on with DEA, or went on with DEA in 1988. I had been working with CPI here in Montrose, and had been working the street drug aspect of things, and with the guys that were here that traveled the Western Slope, and were putting handcuffs on people because they were dealing in heroin and cocaine and whatever the drugs were then. I left here and went to San Antonio, Texas, which was my home for the next 9.5 years. And in San Antonio, I did my, what we call street work. That was where I was an investigator actually on the street, doing the investigations myself with other people, rooting in and getting to be snoopy and knowing what was going on. A couple of cases, the first couple of cases that I worked, I'm just going to breeze through them so you can kind of see what we were seeing at the time. My very first case was a dentist in Austin, Texas. And we got a call from the Austin Police Department, and they had gone into this dentist's apartment on a welfare check. And they didn't know what to make of what they found. They found prescription vials all over the place. They found phone books that had things circled, and they found a doctor that was passed out. So they called us and said, "We think this is your deal, come up and do it." So what we found out was that this dentist, very young out of med school, had gone to work for an organization that had extremely high pressure on what young dentists needed to do in order to have a chair in their office. And, I mean, almost superhuman, really. They would have them come in and have patients come for a first free checkup, but the dentist was told that they had to schedule a good $500 to $1,000 worth of work before that patient could leave the room. And this was what was going on. And this dentist was trying his best to hold life together. Well, he started taking, he started taking some of the medications that were there in the office, and he got hooked. Well, his life quickly spiraled downhill, and the phone books that were in his office were as you could say, his maze for a mouse. He would get up in the morning and he would look at the phone book, and he had circled and crossed out the pharmacies he had already been to. And he would hit a different part of the city of Boston, and he would run over there and hit multiple pharmacies in the same day and write out his own prescriptions, take them back to the office, take enough to get through that day. And you can tell that that would spiral out of control really, really fast. It was interesting because he was my first case, and maybe that's why I remember it so well. But I also want to say that that same young dentist went into treatment, and about 5 years later, I heard his name and I sat up to listen to what was being said. He was doing really, really well, and he had gone through treatment, and he had pulled life back together with the help of a team. And so that was always something that was in the back of my mind, is you could take a person that was so desperate, and like that little mouse that was just running in the wheel trying to stay on top, and still become okay again. Another case that we worked while I was in San Antonio was a physician who, in 1988, Texas was still kind of the Wild West, and I suspect a lot of the United States was. As far as narcotics, as far as the drugs, as far as really elevating physicians to a position that they shouldn't be questioned, that whatever a doctor said was what was right, and therefore you just go along with it. Well, I would say even today, 98% of the physicians in our country are worthy of that kind of a respect. But that 2%, oh my goodness, the problems they can reap in a local community and the heartache they can bring. And this particular doctor was located in downtown San Antonio, and he had two particular demographic groups that found him. One was out of Arizona, and the other was local to San Antonio. Neither of these groups knew about the other group. They operated independently, but they found him to be an easy target. And his requirement was anyone who walked in the door to his office with a legitimate ID, didn't have to be their ID, okay, but an ID that was valid, as in it hadn't expired. It didn't matter what color the person in the picture on the ID was, or what color the person was who was presenting it. It just had to be an ID. An ID and $500. He would write out a prescription for 100 dilaudid 5 milligram tablets, or 2 milligram tablets. Well, dilaudid was the catch drug at the time. It was very potent. It was a Schedule II narcotic in high demand on the street, and people on the street wanted dilaudid because it had the D on it, so they knew it was the real thing. It wasn't an imposter drug. It was the actual dilaudid. Well, the group that was in San Antonio that was knocking on his door were very cagey. They had a group that were all ex-military, and they had access to Fort Sam Houston down there in San Antonio. So they would get their prescription that they had just paid $500 for, and they would take it to Fort Sam Pharmacy, and they would get it filled for free, and they would turn around and go sell those pills on the street for $80 each. Now 80 times 100 minus 500 is still a whole lot of money. And that's what they were doing. And they had a whole circle of people that were doing it. And they were paying people to be the runners to take the prescription out to Fort Sam. And that took us several years to put the whole thing together to where we could get the prosecution to be on our side. And even then, it was still a doctor, and how did we know that that wasn't the right thing to be doing? So I will say that eventually we got the doctor and his nurse, both went to federal penitentiary, and the doctor died there. So he got his just dues eventually, but it did just take a lot of time, and the devastation that was wreaked on the community was horrible. One last story from my San Antonio years was a little town called Del Rio, out there in West Texas, down on the border. And Back then, we didn't have a lot of automation, so we still got a lot of paper. And it was a slow Christmas break, and I was at home. And I picked up a bunch of these forms that came into the office and was flipping through them. And I went, wait a minute. This physician has been going to local pharmacies in Del Rio and picking up bulk quantities of narcotic drugs, which was rare. Why would he need that much for his office use there? And I suspected strongly that he was addicted. And so we began following that trail, and by New Year's, we had been to his office. We had not only realized he had an addiction problem, but his wife did as well. And they were off at some ski lodge in New Mexico for the holidays, so we had a little bit of time to kind of put the picture together. But the truly bizarre thing was, this doctor had been delivering probably 95% of the babies in Del Rio. And someone said, well, is he doing that while he's high? What's going on? Well, then we started finding out that there had been some situations where the babies had been injured during delivery, and probably because of his not being in his full capacity. But as the story got crazier, we found out that shortly before he left for this vacation in Mexico, he had delivered the baby of an illegal immigrant woman who disappeared from the hospital, didn't want to be caught, and left a note there that she was turning the custody of her baby over to this doctor. Well, the doctor and his wife had been wanting children for a number of years, so the doctor picked up the baby, took it home, gave it to his wife as a Christmas present, and off they went to New Mexico with their newborn baby and a whole carload of drugs that he had just picked up from the pharmacy. So, again, just bizarre things. So when I hear the opioid epidemic is new, no, it is not a new problem. It has just finally come to the forefront where it deserves to be, so that people are aware of the situation. After 9.5 years in San Antonio, I was transferred to get an office started in Waco, Texas. I was there for about 15 months. I was promoted to become a supervisor, and I moved to Columbus, Ohio. In Columbus, I was met with new things that I had not dealt with before. One of them was pseudoephedrine, which I don't know how many of you are aware of that, but pseudoephedrine is one of the key ingredients in methamphetamine. Pseudoephedrine also has a legitimate, it was not a controlled drug, okay? It's just an over-the-counter thing. But it was disappearing off of Walmart and Walgreens shelves. I mean, the shelves would be cleaned up. They'd put it out and it was gone. And law enforcement came up with the term smurfing, because these people would literally go from store to store, clean off the shelves, walk out the door, and it would go into making methamphetamine. There were some deep, dark players in that as well, who were bringing it in and getting DEA registrations as distributors. And as it started unrolling, and this was kind of a national issue, it was East Coast to Ohio, and then it kind of skipped over to the super labs out in California and down into Arizona. But huge volumes of methamphetamine were being made, and they were calling them super labs. These weren't the little tiny, at home, put a few things together, shake up the bottle, let it sit a while. These were volume quantities. So what the federal government did is they said, we got to get that stuff off the front row of the shelves where it's accessible. It became a listed chemical. That had actually happened back in the 80s. But now they added parameters on it to where it had to be stored behind the counter. So if today you're having allergy season and you have to go to the pharmacy counter to get something that is not even a prescription drug, that's the reason why. Okay, because they had to get it off the front, they had to get it off the shelves. So I was dealing with pseudoephedrine, and then another very strange phenomenon. And I guess this is where we talk about the opioid epidemic as we are identifying with it today, okay? 2000, Purdue Pharma produced a drug called OxyContin. OxyContin was an immediate hit. It found its way into being the total economy of small towns along the Ohio River into Kentucky and West Virginia and over into Pennsylvania. The marketing plan for OxyContin was, we will take this directly to the doctors, not specialized physicians, not oncologists, not the ones that you would anticipate having access to it, but to the general practitioner physicians who had just not ever dealt with a drug like that, that was a killer and that was so highly addictive. We said they went to every hill, valley, and vale and holler in Kentucky and pushed this. Well, what we saw in Columbus, which is where I was at the time, was huge numbers of people getting addicted. A few doctors got in trouble with the law. We were able, after time, to get them stopped to a degree. But if you take away the source, you're still left with addicts. And those addicts have a powerful motivator that they still need whatever they're addicted to. Well, pharmacy robberies, armed robberies of pharmacies, all up and down the borders of the highways, from Columbus down to Portsmouth, which is on the border with the river going into Kentucky. Bad bunch of docs on the Kentucky side, they'd flip-flop back and forth across the river. It just devastating. I personally went one time, I had seen the third armed robbery report on a specific pharmacy that was located not far from the office in Columbus. I thought, I just got to go see this place and figure out, why is this the target? Why is this what's going on? So I went and walked in the front door, and here's the waiting room. Doctor's office is over to the right, and right here behind it is the pharmacy counter. And right here on the wall going into the pharmacy is this repair to the drywall that looks like a truck had driven through the drywall. So I started talking to the pharmacist, and he goes, oh, that was just the last time? That was the third time? And I said, so what are you doing as far as your responsibility at this point to prevent that from happening again? And he says, well, the doctor wants the OxyContin. And I said, okay. I said, that's kind of his issue. Your issue is you want to carry it. So if you're going to be carrying it and you're going to be filling these prescriptions, what are you going to do to safeguard it? And so we had to have a sit-down, very serious conversation about where he was storing it in the pharmacy. Obviously, a whole lot of people knew he carried it, which was the problem. And he began putting certain things in a safe, and the OxyContin being one of them. While I was standing there talking to him, there was a knock on the back door, which had at one point been a delivery door, but it now had shelving across it because he wasn't using it for deliveries anymore. And there's a knock out there, and I looked at him. He says, just a minute. He calls one of the gals from the doctor's office. He says, would you go out and peek around the corner and see who's standing out there by that door? She came back and she goes, he has a mask on. He says, okay. So he just ignores the knocking, and finally the guy drove away. But we were in, I mean, there was a potential that we could have faced an armed robbery just literally while I was standing there in the store. And those stories were repeated again and again and again and again. OxyContin created a stir like nothing else has, and I'm sorry, but I'm going to resort to reading to you for just a minute here. You might ask, what was the shift that allowed, why was suddenly all these narcotics being prescribed for things that were not end of life, they were not serious conditions, health-threatening, keep the person comfortable? Well, very interesting, in 1981, there were a couple of doctors, their names were Porter and Jick, and they authored a couple of lines that they put in a letter that was simply an observation. This was not research, this was not a proven anything. And their comment was, from observing a few cases in their practice, which happened to be patients in a hospital room, not patients that were going out on the street, that addiction seemed to be very rare if narcotics were properly used. They never meant for that to gain the traction it got. It was published as a footnote in the New England Journal of Medicine. And from there, it got misquoted and misused, and Purdue Pharma was one of the biggest offenders of that. They picked up on it and they said, "Oh, Mr. Canfield, Dr. Canfield." They picked up on that and it rolled. And that became the basis for the next 25 years, still today, is finally people are beginning to realize that was not true. But there was a period where the floodgates for the writing of prescriptions for opioids for narcotics was just wide open. And everyone was using that little line, those two lines from those doctors who never meant it to go that way as their reason for what they were doing. Purdue Pharma picked up on that. They went out and they directly marketed it to the physicians. And then you get into the scandals that you hear about of them offering, prizes and trips and good things to the people who, would support their mission to sell drugs. Just recently, I read an article on the Sackler family, which is big in the news right now. The Sacklers are the founders of Purdue Pharma, and they are finding that the Sacklers are also sitting on their own board. So yes, they as individuals were aware of the decisions that were being made and of the promotion of these drugs. There's a quote that was picked up on by, I believe it was the Metropolitan Art Museum in New York, and there was a demonstration stage the other week. The quote from the Sackler family in personal emails back and forth was, "Let's see blizzards of prescriptions." Blizzards of prescriptions, because it would make them money. It had nothing to do with the treatment. It had nothing to do with the welfare of the people. Okay. How am I doing? 21. Okay, great. So I went from Columbus, Ohio. I went into DEA headquarters, where I saw the, quote, infamous big picture of what DEA was across the nation and why we made the decisions we did and how policies were started and formed, and that process. It was fascinating to me. I guess I was enough of a government geek by then to find that interesting. But I had seen enough problems out in the field. They were like, why did that get to the point where it got? Why was that allowed or not allowed? So it was an interesting time after a very short period. Hooray for me, people tend to get stuck at headquarters for years. I was able to spin out in less than 2. And I came to Denver and spent the last 14 years of my career in Denver. So in Denver, and over my 14 years there were a couple of significant things that happened. One was the phenomenon called internet pharmacies. And in the Denver metro area, we had order pharmacies that could be any pharmacy you see here in town, but the unusual thing was their consumption of narcotic drugs started just spiraling out of control. And the question, of course, was why? What has changed? Why did they need all these drugs? Well, someone had devised a plan, and the plan was to make money, and the plan was to use the internet. And so when we would go into a pharmacy in Denver, Colorado, and say, "Whoa, what are all those things you're getting ready to FedEx out?" And they'd say, "Oh, that's today's orders." And literally FedEx was adding to their route to come and pick up all these orders that were getting shipped out. The prescriptions could be from a physician in Puerto Rico from a physician in Florida, from a physician in Minnesota. And the patient could be from California to Maine to Florida. And a pharmacy in Denver, Colorado, and this was being stamped across the country. This wasn't just a Colorado phenomenon. Obviously not what was intended to be happening with these drugs. Okay. And so there were a lot of rule changes in medical boards during that time, identifying what a legitimate doctor-patient relationship was. And go figure, at some point you had to actually see the patient face-to-face and examine them. Rather, and I mean, things that seem common sense, but there was a group of bad apples that made millions of dollars off of that before that was finally brought to a stop. The biggest thing that happened that brought that and wrapped that up was the death of a young man out in California named Ryan Haight. A law was passed and given his name, and it put some restrictions and requirements on what could be a legitimate internet pharmacy. Now, you and I probably all know, if you have a health plan, that sometimes you can go online and request your refill. It might get sent to you from Florida, from one of the big service centers. But those are legitimate now, okay? And there is a way of tracking which pharmacies have complied with the requirements. And when DEA finally offered a registration for legitimate internet pharmacies doing the kind of business that I was just describing, does anyone want to guess how many applicants we had? No one was willing to sign that paper and request a registration saying that this is what they were going to do. Okay, so that was going on in about 2005, 2006. In 2007, nationally, the DEA and the U.S. Attorney's offices finally took a stand against the distributors themselves of drugs and said, you guys are not doing your part to avoid this problem. You all have a responsibility. And you cannot turn a blind eye anymore. So there was a big lawsuit that was done. It was record-breaking at the time. Honestly, I don't remember what the settlement was anymore. But as key to the dollar figure was a memorandum of agreement that was drawn up that said that the big distributors, the three main ones are McKesson, Cardinal, and AmerisourceBergen, that they were going to redo their regulatory system. They were going to be more diligent about screening the orders they were filling. They weren't just going to fill any old order, da-da-da-da-da-da-da. Sounded good. Didn't work. Over the next several years, and I can say this because this is a settled case, that singling out a particular one, McKesson Drug Corporation, filed exactly 3 suspicious order reports in that many years. They all happened to be filed, well, this was our local in Denver, our facility that I knew about. They were all filed not at the time the problem occurred, but at the point where they cut the customer off because they decided it was a problem customer. And we jumped on that in Denver, and we began with the U.S. Attorney's Office to take a really serious look into the distributors and what were they doing? Had they complied in any way, shape, manner, or form? And the decision was basically that no, they had all written really nice checks, and they had signed the right line on the memorandum of agreement, and they had said they would do all of this, but they really weren't out watching for the public health and safety. And so we began a 2-year, 3-year case. In Colorado, we came up with the idea of looking into sales to pharmacies, and rather than having it be obvious like all the pharmacies around a medical center or something like that, we picked and chose pharmacies spread across the state of Colorado, rural, city, next to a medical center, way away from the medical center, took that information along with what we knew from the medical board and from a system called RADARS, which is run by Denver Health, that keeps track of overdoses and addiction issues. And we put together a plan and said, okay, there should be a variance, right? If you come from a town of 700 people as opposed to metro area Denver next to the medical center, there shouldn't be any relationship really between the number of pills that are going wrong. They were just going to these places no matter what. And we had situations in the San Luis Valley where little tiny burbs of towns were ordering and receiving enough hydrocodone tablets, which have been moved to a Schedule 2 from Schedule 3, to give every man, woman, child, baby a 30-day supply. And it was absurd. And this was happening across the country, everywhere that we would look and everywhere we went. So it took several years and a lot of finagling, and ultimately another civil case was settled with McKesson Corporation. And we did this time put some limitations on their DEA registrations, but I will tell you it was a fight. And I will tell you that the politicians are right in there, and the lobbyists are right in there, and everyone has their own game they want to play and their own reason for wanting to see this go untethered. And it is a mess. And so if you want to know why we know the opioid epidemic the way we know it today, that is the reason. Okay, and you've got to put the blame right at the top. Those pills would not be hitting the stores. They would not be hitting the population if anyone was trying to do something to put a stop gate at the top. So I retired. The last 2 years, well, a few years before I retired, I had the privilege, and I say that immensely because I had always, from the days that I worked with CBI clear back here, I had always put a high price on working with the state and local entities. I just found we had to. We weren't separate. We weren't better than. We were just had a different mission. And so I had always worked with the state regulatory boards and people who were doing treatment and the food and drug people. And so we had all kind of become this little clique that all knew each other up there in Denver, and we would get together and we'd talk about things. Well, in 2010, Colorado was recognized by CDC in an article that had to do with self-reporting of drug abuse by students, which was looked at as age 12 to 24. Colorado was the second highest in the nation for the use of drugs, and it was largely hydrocodone. The governor at that time had had an invitation to work with the National Governors Academy, and he pulled together a group in Colorado. I had the privilege of serving on that group. For 2 years, we brainstormed about what did Colorado have, what didn't it have, what did it need to have to address this problem. And the long and the short of it is out of that, there was formed a group called the Consortium. And I'm going to introduce someone in a minute, and I'm going to let her say the whole name because I'll get her wrong. But as of today, as of this year, I believe, it has actually become a center located on the University of Colorado campus, the Anschutz campus up there. A dear friend of mine, Dr. Robert Valek, who has traveled the country speaking on these issues, has been named the director of the center. It has become a real thing, okay? It is grounded, it is supported by the right people. All of the state agencies that are involved take part in the leadership of these committees. There are working committees that have been set up addressing everything from abuse and addiction and treatment to law enforcement. Jessica will talk more on that in a minute. And tonight, they are actually having a first step forward with something called storytelling. And this has been long coming, but this is families who have lost a person to drug addiction are getting a chance to tell their stories in a very professional manner and make that available to people to hear. And that is groundbreaking news that's happening tonight at the university. So with all of that said, I would like to introduce someone who is, I just met her this morning, we've been communicating on the phone, but she is with the consortium. She lives in Salida. Montrose County is one of her counties, right? Come on up, Jessica. Her name is Jessica Edie, and she is going to talk to you for a few minutes and tell the rest of the story that I'm forgetting now. Thank you, Jessica.
Thank you. I am not as good of a storyteller as she is, and my stories are not that exciting, so I'm not going to try to compete. I'm just going to summarize a little bit about what we know about Montrose County specifically, since we're all here in Montrose County. And then I'll talk a little bit about what she started to describe of the efforts going on at the state level to help individual counties to address this problem, including Montrose, which is in my region. So we know that in 2017 there were 1,012 drug overdose deaths across the state of Colorado. This has increased from 2016 data, which was 936. Majority of these drug overdose deaths do involve opioids, both prescription and illicit. And in Montrose specifically, when I looked at the data from 2013 to 2017, we had 23 drug overdose deaths total, and of those 11 were prescription opioid related. I didn't get a count of heroin, but I can say that Montrose falls in one of the lowest tiers in the state for heroin overdose deaths. So we're still looking at, oh, thank you, I'm getting confirmation, that's always nice. And so I can say that we are still struggling more in this particular area with prescription opioids over heroin and fentanyl. However, I also cover Pueblo County, and when I've only been here for 2 years, but last February we saw this big spike in fentanyl deaths in the emergency department admissions in Pueblo, and now it's 6 months later, well, I guess we're at a year later, we have found that 66% of the fentanyl test strips are coming back positive for fentanyl being laced into all of the drugs in Pueblo. And so I say that just to illustrate that even though we are the lowest tier here, and where I live in Salida, we really haven't seen that hit yet either. It can happen within like 12 months. It just takes one, as she said earlier, 2% of the people can cause a really large problem for the rest of us. So I just want to put that in perspective for Montrose. I'm happy to share more data. One of the things we do at the consortium is we have access to different sources of state level data. We can share it with communities and talk about specifics or answer questions, but I didn't want to bore you with a data presentation, especially after her really interesting stories. So my role is in the external relations strategist for the consortium. What that means is that I work in local communities and help them to address the opioid epidemic and prescription drug use in general. My background is that I was a substance use treatment therapist in North Carolina. So I was a clinical social worker and a clinical addiction specialist. And I've transitioned into more policy programming work now, but I have a very different background. However, I think one really cool thing about the consortium is that people who do have a law enforcement or investigation background are partnering with people who have a treatment background, who are partnering with people who are epidemiologists at public health and policy makers in the legislature. So I do think that we have an effort that we're moving forward with a pretty diverse group of people. So a couple things that you can do just sort of as a takeaway after hearing all of the bad news. There is good news. So one thing is that naloxone is it's a medication. It's a nasal spray, and I have it on the back table. Not the real thing, unfortunately, but a demo of what it looks like. But it's essentially a nasal spray like you take for allergies, like Flonase or any other nasal spray. And it will actually reverse an opioid overdose within 3 to 5 minutes of administration. And so for those of you who are medical professionals, it's an opioid antagonist. It is available to anyone in this room without a prescription under standing orders under the state of Colorado. So essentially, the medical director for Colorado Department of Public Health wrote a prescription for every resident in the state of Colorado to be able to walk into a pharmacy, request to have naloxone. It's called Narcan by brand name. And that's something that you can carry with you. The Surgeon General came out with a statement last summer saying that he thinks every single person in the US should be carrying Narcan, and we should all be trained to use it like we are with CPR or any other life-saving measure. So that's one thing. And I have information packets about it and how to use it on the back. Another thing is, as she talked about, prescription opioids really were the beginning of this issue. And so one way that we can help, all of us can help to prevent it, is to store our medications safely and dispose of them properly. So there are medication drop boxes in every county but 3, I think we have left, in Colorado. So Montrose has drop boxes where you can take your unused medications, whether it's prescription opioids or anything else, and dispose of them in a safe manner so that when people come in, we've seen cases where maybe you're selling a house and someone comes in and goes in to look at the house, but actually goes into the medicine cabinet and pulls out the drugs in the medicine cabinet and then leaves. And so issues like that, or maybe if someone come to fix your heat, they go in, they ask to use the bathroom, they check the medicine cabinet, and then they leave. So we're trying to really encourage people to either hide their medications or lock them up, preferably. And that will help cut down on the access and availability of these medications in the hands of people who maybe are struggling with a substance use disorder and need to seek treatment rather than seeking more medication. And then getting rid of them at the end of the prescription is just a really concrete thing we can all do. So go home, empty your medicine cabinets, take it to a drop box. And then the last thing I wanted to talk about is access to treatment. So as she described in her first story, I think this is a disease of, it's actually been labeled a disease of despair. And there's 3 main diseases of despair is the new term for them, and it's alcoholism, drug overdose, and suicide. And we've seen a huge increase in those across the country. And I think disease of despair really captures the fact that no 5-year-old grows up and thinks like, oh, I want to be addicted to heroin, or I want to be addicted to opioids. They think I want to be the dentist, I want to be successful, and that's not their life goal. So trying to increase access to treatment across Colorado, and especially on the western slope and in Montrose, is a high priority for us. And so there's several bills that are proposed right now in the legislature, and you can follow them if you get on the Colorado legislature website, that would help increase access to treatment. Some of them are doing mobile vans of treatment across the western slope. So I would encourage you, just if you're politically active, to continue to encourage access to treatment, especially in rural areas out here.
Maybe open it up to questions.
So for those of you who haven't been here, if you have a question, just raise your hand. I'll get the mic to you, and we'll circulate around the room that way. So questions?
I have one question, concerns marijuana. It's a federal violation to have marijuana, but in states that allow it. How's that working out for you?
How's it working out for anybody? It's a mess right now. It's something that needs to be fixed. It's a mess. I mean, you have federal law, you have state law, you have products that are being out there that are being sold that have none of what we call the regulatory checks and balances for what we in this country have always referred to as medicine. There's no dosage information, you don't know the strength of it, you don't know if it's going to be repeated again I mean, it's a mess. So I'm waiting to see where that goes. Go ahead.
Can you talk a little bit about fentanyl?
Okay, yes, briefly I can, and I'm glad that that came up. I just actually went over to the DEA office this week for the first time in 19 months since I walked out the door. And my reason for going was to say goodbye to the fellow that had been my boss because he's getting ready to retire. And I spent a couple hours with him the other day, and as we chit-chatted, he was talking to me about fentanyl. And he said that fentanyl has hit the state very hard. I don't know what it's doing over here yet, but he said there are a lot of tableting machines that individuals have brought into the state from out of country. Usually they come from China, and you can order them online, and you can bring in a tableting machine, and people are turning out these fentanyl tablets. They're also spiking, as she said, almost any of the street drugs that are out there. But they're also making fentanyl tablets, which is scary because that means it looks like the real deal. It looks like an actual pill. So it's here. It's not going away anytime soon. It's a highly deadly chemical. And when used outside of the medical realm in the way that it's meant to, is a killer. Okay, so it is here. Something else, and I've got to put my punch in for cleaning out your medicine cabinets. About 10 years ago, sitting in my seat, I was told that I was the Colorado person to figure out how to do the National Drug Take-Back initiatives, which I know both your prior sheriff and chief of police were very supportive of here. I don't know about current. I'm not trying to slide anybody's hand, but I know that when I was sitting in the chair that I worked closely with Tom Chin and with Rick Dunlap. The medicine cabinets is a huge deal. I forget what the percentage they say of like a lot of the drug overdoses and uses do come from grandparents, parents, friends, neighbors, medicine cabinets. And the kids, we were all kids, we lived through it somehow, but there's this thing that is called Skittles parties, or they're called fishbowl parties. And your admission to the party is to bring something from home, and it goes into a bowl, and you mix it up, and there's a nice bowl of all sorts of pretty colored things that no one knows what the heck they're taking. And that's your entertainment for the evening, is to see what happens when you take those pills. And there was a horrible car accident in Highlands Ranch over by Denver a few years ago, where 4 high school seniors just left a party and they had on someone and they all died. There was a kid that was driving past a grade school, right as school got out, turned into a neighborhood, I know a friend right there on that street, and hit 2 elderly ladies that were coming out of their driveway. This is messed up. This is messed up. I cannot tell you seriously enough. And this is not a disease that knows demographics. It does not depend on economics. It doesn't matter who you are. It doesn't matter what race, creed, religion you are. It will find someone near you. Do not be blind to it. And do keep your medicines under wrap. And take part in the NTBI.
Question.
Yes.
So some countries and some people advocate the decriminalization or the legalization of drugs as a solution to these problems. And I think if we go back the opioid history, these drugs were legal at the turn of the century, and that's where all this regulation stemmed from. Initially, is that we had problems with opioids because they were not controlled.
I'm not sure where your question is in that. And I don't know how to respond to that. But thank you for your observation.
Other questions?
You mentioned the drug take-back programs where things can be dropped off. Over the last number of years, there have been things in Montrose tied to the health fair or other things where there's an advertisement you can take drugs, drop them off. But I don't think there is information out to people for other times than those specific dates. Are there opportunities at any time to drop them off at a doctor's office
Okay,
or
well,
police department?
No, they cannot.
Hospital. There's a box in the hospital lobby, which is open to everyone. And it's a take-back program that's anonymous. They don't take Schedule 1 drugs, that's heroin and that kind of stuff. But they take all your prescription drugs. And it's open to anyone, it's anonymous, and we fill that box up on a regular basis. And you can come in the hospital any time of the day or night, into the lobby, down next to the emergency room, and the box is there where you can put
But that
used
information
drugs.
needs to get out to the general public.
Yeah. Jessica would like
We,
to say
we also have a National Take Back Day on April 27th, this April 27th.
Other questions?
So back in the 70s and 80s, I was a paramedic on the front range, and we routinely administered Narcan. And, you know, at the time, we thought we were saving lives. But I saw a 60 Minutes report of the revolving door between upper DEA and FDA officials into Big Pharma, who helped write legislation for Congress to pass along with contributions. I was extremely frustrated. About seeing the same people over and over again. And I felt that some of the comments that you made, you had a degree of frustration also. Could you speak to that?
I'm not really certain, how to respond. I know the policy-making efforts can be difficult at best, and that there are a lot of different viewpoints that come to tables, and the way those things get resolved don't always cut one way or another. I think they try to do the best that they can do given the circumstances. I will tell you there is an extremely powerful lobbying effort in this country with a whole lot of money that crosses hands, and that politics is far more involved, in my opinion, in some of these processes than it should be. There should be more anonymity of separation. Why should this be something that is lined up within the government as far as some of the decisions that are made? These are not something that should be because you're conservative or because you're liberal or because you stand to make money off of it. It should be for the good of the people. That's what we're saying.
I can speak to the revolving door part of that. So I think that when you look at addiction as a chronic progressive brain disease, which there's increasing evidence if you look at MRI scans and if you look at National Institute on Drug Abuse and if you look at lots of different research organizations, it has a relapse rate actually comparable to diabetes and hypertension. And those are other, as we all know, chronic progressive diseases if they are not treated. And so I get the question, well, what does it mean to relapse in diabetes, And so that means you're not taking your insulin, maybe you have to go to the emergency room or change your level of treatment and increase it. And I think that because we have viewed drug addiction as a moral failing for so long, I was raised with that perception as well in the South, that we have tried to treat it as okay, well, we've given you Narcan, we've sent you to detox, why aren't you better? And the truth is that it is a disease that usually on average takes about 7 times of relapse before someone enters a long-term sustained recovery, and that's usually defined as 5 years of not using. And so I think that it is frustrating. I've also worked with the same clients from the therapist perspective, and it is really frustrating to watch, and it's heart-wrenching if it's someone you love. But at the same time, dead people don't get well. And so if we are going to try to help people to get into recovery, we really do just have to be prepared to give multiple doses of Narcan multiple times. And I'm happy to go into the brain science at a different time, but I'm being cut off.
You are. It is 9 o'clock. We always stop promptly at 9. So if you have questions that you didn't have the opportunity to ask, will you both be here for a few minutes?
No, I'm out.
You can try and catch them. How's that? How about a round of applause?